Now it's time for the panel discussion. The topic for panel discussion is a question. Is there a role for other imaging modalities besides CT? The first case, 38-year-old patient, was referred to the hospital with cough, fever, and left chest pain. I would like to invite Dr. Vollmer.
Thank you. Well, it seems to be a large left pleural effusion that it seems to be loculated.
What do you want to have another modality? Ultrasonography, CT, MRI, and why?
I prefer to use in this setting ultrasound because it allows to see if the effusion is complicated.
This is ultrasonography.
Obviously, it's complicated effusion. It's a complicated effusion with the internal septa.
Yes. This is the procedure.
Well, you can see here in this image the needle inside the pleural space, the wire, and after that, with fluoroscopy, yes. You can see here a catheter.
Yes.
Can you come back on the ultrasound picture? Would you try to go with your lineage through the different septa?
Yeah.
Destroy the septa?
Yeah.
Yes.
Yeah?
Yeah, sure.
Yes, you can try with ultrasound to rupture all the
yes.
septa that
sure.
you can.
Also wire. I mean, with wire, it's possible to rupture some of the septa formations during the procedure. That's a very simple method to destroy them. Yes. And because of the septations, we carried out more than one catheterization, and fibrinolytic agent also was used to rupture the remain septa formation, and the result was a successful result. Okay, thank you.
Can I ask?
Yes, please. Well,
What is your regime for the fibrinolytic agents?
what is?
The regime for the fibrinolytic agents, TPA or WDF?
In fact, we used streptokinase, the 200,000 units. We injected it with 50 cc SF and closed the drainage catheter for 4 hours and then open it back. If the septa formation remain inside of the pleural effusion, we can repeat it once again. But of course, TPA and urokinase are better than streptokinase because of the risk of complication. But in our country, streptokinase is available in the market and cheap. That's why we prefer that.
Do we know, is there any advantages to aspirate first and then to inject streptokinase, aspirate the fluid and to inject streptokinase, or you direct inject streptokinase inside the fluid collection?
In fact, I prefer to use it after the daily drainages. I mean, if the daily drainages comes down, reduce in time, after that, I prefer to use fibrinolytic agent, which means that we first aspirate and then we carry out the agent. Thank you very much, Ivan. I would like to invite Philip. Yes, please. 85-year-old male patient with urinary bladder cancer. We decided to carry out radiofrequency ablation. This is the CT scan of the patient.
First of all, do we have to do something? It's 85 years old.
Yes. This is another question.
Okay.
Maybe someone would like to discuss this question as well. Tarun, what do you think?
I mean, 85 is quite. You better first know the prognosis, and where and what speeds metastases are going to increase at, and what are you going to do? They're multiple, they're in both lobes, both sides.
Totally 4.
How many? 4 metastases.
4 metastases.
The problem of urinary blade cancer is that the chemotherapy are not really effective, and the new biologicals are very aggressive. Yes. If you take sunitinib or this kind of biological, is for the quality of life is very limited. And my question before, if we have to ablate that or not, in my opinion, I'm not urologist, but in my opinion, nobody knows if a patient with urinary bladder carcinoma will have a benefit from ablation of lung metastasis. Probably he will develop other metastasis, cerebral metastasis. But if there is also some patient who come to you and they say, I want a treatment. Patients are very good, how do you say?
Wish. To
yeah,
have
they want a treatment. So just regarding the size of the metastasis, all the metastases, as of 4 metastases, and there seems to be smaller than 3.5 centimeters. If we look at this scala here, it's supposed to be the larger one here. We recognize some lymphangiosis here. So if we want to perform ablation, this one is a larger one. And there is some lymphangiosis. So it's, if you perform ablation in this case, you have to perform a very large ablation. The other metastatic disease are without, look, this one or this one, without lymphangiotic carcinomatosa. You have a large vessel here, but it's 1.5 centimeters, could be ablated in one session. No lymphangiotic carcinomatosa. The one, in my opinion, the one is a dangerous one.
This is the CT scan obtained 2 months during the follow-up.
Okay, in that case, we can recognize the residual here, ground glass opacity, probably you came on that way.
Yes.
Probably a residual coagulation of the tract here. There is some aerated area here. It could be a complete coagulation in that case. Here, to be honest, I cannot recognize anything. In that case, I am a little bit concerned about this nodular aspect. As I said before, perform follow-up examination in another window and without and with contrast medium. And I could imagine that there is, if it is a first follow-up examination, there is some residual tissue in that part of the tumor.
Yes. We made MRI diffusion weighted image. And do you want to make any comment on that?
I can comment, but probably like the majority in this room, we have no experience with diffusion imaging in MRI. There is some diffusion, limited diffusion in that area.
Yes.
Yeah, that's interesting because it is a lesion with a small nodule on CT.
Yes.
Also some diffusion area, but we have no a negative IDC map here. no change. The idea here it's maybe a little bit ADC changes here,
Yes.
but my experience is limited.
Okay. 2 months follow-up on MRI, similar features, and 7 months later, what do you think?
So that's very interesting. This lesion is becoming smaller 7 months later. It's what I show in my slide. So only with this window, this lesion and all criteria of a complete ablation. I'm a little bit surprised because I would suspect some residual tissue in that area. The same for this one. This one's interesting. It's a so-called cavitation phenomenon.
Yes.
The cavitation phenomenon is supposed to be a very positive predictive factor for complete ablation after microwave. There is one study on that. A cavitation.
Also RFA as well, I guess.
Yeah, I know about microwave. So, and we see the ground glass, the scare after ground glass opacity almost all around the tumor. So we have complete ablation in that case, also in that case. And I'm surprised we have a complete ablation here.
Yeah.
But you did.
But be patient. This is contrast MRI. Would you like to make some comment on this?
You can correct me, but I do believe I was right. Yeah, you have some contrast enhancement here. Compare with this lesion, for example, we have something like a rim enhancement, incomplete rim enhancement, but a rim enhancement without nodule. Correct me, but
that's right.
Here you have some enhancement, nodular enhancement in that area.
Yeah, that's great interpretation of the case, in my opinion, and because 1 year later, on the CT scan, please.
Yeah, I hope for everybody now, after my small talk, that for everybody it is clear that we have an enlargement of the lesion. We have a very strong lymphangiotic carcinomatosa.
Yeah.
It's becoming larger. You don't need contrast medium. You have a relapse in that case. Yeah.
Yes. We haven't published our limited experience on the MRI, the rollo MRI, on the follow-up of the RFA patients, but sometimes it's helpful. It could be the trick of this case. I don't know if we have still time, maybe a couple of minutes. I would like to invite Tarun to present his case, please. Could you please help him?
Just my slides again.
Oh, okay, sure.
Thank you very much, Philip.
This one.
And then I'll just go to the last 3 slides. Oh, sorry. Is the way of going to the... Sorry, just going to take you through to the last couple of slides. Okay, I was asked to just prepare a slide on where ultrasound would be beneficial compared to CT. We went to the theoretical advantages earlier on about subpleural lesions. We were faced with a patient at Mayo Institute who was young but had been on intensive care therapy for quite a long period of time, a couple of weeks now, and not recovering, in and out of ITU and intensive care and high dependency unit, multiple areas of co-infection, and there was a concern, and she was actually so bad that she was being put on high-frequency oscillation as well at the time for ventilation. And a CT scan at various stages in her treatment when she was stable and was brought down, well, these kind of images you had. And one of the concerns then came up to our respiratory physicians was really, why is she not getting better? Has she got an underlying cancer or some immune suppression? And it was this lesion that was seen at the right lower lobe here. I was unsure, is that consolidation? Could there be some underlying cancer there? But she was not very fit to come back to CT. She really did need a high oscillation frequency in ITU. So this is kind of stage where we went to ITU with the ultrasound. They could stop the high-frequency oscillation during the period of our time. And under ultrasound, we could target this lesion here. We biopsied it, and it came back as adenocarcinoma. And given this, the family were then or the doctors were able to talk to the family and make a better prognostic evaluation on a more aggressive treatment or not. So it just gives an advantage. Everything doesn't need to be CT. Ultrasound is very helpful. It is very portable compared to CT. And you can have a reasonable result.
Yeah. Okay. I think now the session is over. I'm delighted to close the session. Thank you very much for your participation. Thank you.